presentation is entitled Looking in Two Directions: The Implications for Linguistic Theory and Clinical Intervention of Research on Developmental and Acquired Impairments in Sign Language. Thank you.
Thanks, Ronnie. Sure. Right. Hi. Sorry for the very long title, but I'm going to try to take you through what I think is one of the most important contributions of sign language and sign linguistic research, which is... Sorry. I'll move the microphone closer to me. So I think one of the important issues... I should sit down, I'll be even closer. I'll stand. So I think one of the really important things is that doing research on sign language can not only inform practice with deaf children and adults in the deaf community, but it actually tells us something about language and people and intervention more generally. I'm not going to go through all of this because you've seen them in relation to acquisition and so on, but I'm going to be talking about people who have atypical, non-typical sign language, and by that I mean people who have some language disorders. And I'm going to argue that when you look at these atypical signers, you see things that would otherwise be overlooked not only by spoken language linguists, but also often by sign language linguists. So there's a value in itself in looking at this population, but I'm going to go on and show how actually this research can have very profound impacts on, in this case, I'm going to talk primarily about health care, but I'll also talk a little bit about education. So when we start looking at impaired sign language, we want to know whether these impairments are the same or different from those in spoken language. This is like what Diane was saying about acquisition. Is it like spoken language acquisition? Is it different? How common are impairments in sign language? Am I just talking about a few? We can stretch. The next time this comes up, we're taking a break. And also, what can these impairments tell us about language generally? So we have done a lot of research at DCAL, and before DCAL was founded, we've looked at impairments in hearing and in deaf signers. And I've just given you a long list here. I'm not going to explain what they all are, and I'm not going to talk about them. We've published reports on most of these. I'm really only going to talk about two things today: autism and stroke. And then I'll talk about healthcare. So signers with stroke, we've always known that in the hearing population, left hemisphere damage, right, left hemisphere, that's where language is associated with language impairment. The same is true for signers. And for both hearing and deaf people, strokes on the right side of your brain are not associated with impairment of language, whether it's a sign language or a spoken language. So here's a group study that we published a number of years ago. In blue, we have deaf people who are signers who've had right hemisphere strokes. And in red, we have signers who've had left hemisphere strokes. So in naming and in noun comprehension and in sentence comprehension, people who've had right hemisphere strokes behave very much like people who've not had strokes. And you can see that the people who've had left hemisphere strokes are impaired at naming, seeing a picture and saying what the sign for that is, in understanding single nouns and in understanding sentences. So the pattern is very similar to that for hearing people. If you look at a particular kind of sentence comprehension, so sentences that are locative in nature, and I'll show you a picture of a typical test item. So the target is the pencil is on the book. And in this task, we had people look at two different ways of signing that kind of sentence, either with a preposition, a sign on, or with a classifier So piece of paper and a thin object on a flat object. And here we can see that the healthy deaf signers find this a very easy task. Actually, both groups of signers are impaired on this. The people who've had left hemisphere strokes are equally bad on the two kinds of sentences. But the right hemisphere stroke patients are actually worse at the preposition construction. Okay? Sorry, said it the wrong way around. The right hemisphere group are equally impaired on both administrations, and the left hemisphere group are better with classifiers than with prepositions. We think the reason is that the failure of the right hemisphere group, no matter how the task is given to them, is because they have problems with spatial processing associated with their right hemisphere stroke. This is well known for everybody with a right hemisphere stroke. The left hemisphere group appear to be worse at prepositions, and we think that's because those make greater demands on memory. When you have a classifier construction, the simultaneity there helps preserve some of the structure. So even with the slower processing of somebody who's aphasic, they do better. So just to summarize what I've said, for most tasks, people who've had right hemisphere strokes behave perfectly normally. They're not aphasic. When they have to process locative constructions, the people with right hemisphere strokes are impaired. As I've said, we think it's visual spatial impairments. And they're equally bad whether it's prepositional, so very kind of serial syntax, or classifiers, which people have argued contain some gestural elements. And the left hemisphere patients are worse on prepositions. Okay. If we look at right hemisphere stroke patients, they seem to have problems, we've said, with visual spatial skills, and they also seem to have problems with face processing. So we wanted to look at those skills and also at those bits of language that are expressed non-manually. Now the question is, if you have problems processing faces, will you have problems with something like negation where there's no manual negator? So the right hemisphere group of patients were impaired on all of our tests. Here's a facial expression that you certainly wouldn't say it's happy. I mean, I think we'd all agree this is a face that looks worried, unhappy, anxious. I mean, there are lots of signs you could use, but not nonchalant or happy. So these people really do not understand facial expressions. So we did a task on negation, and basically it's a very simple task. You have two choices. You either see the researcher sign a sentence like, has a bone, which I'll show you. Bone have. Or a negative version of that sentence. I'll show you first the version with the hands and with the manual negator, and then the version without. Okay. And on the positive sentences, has a bone, I mean sentences like that, the right hemisphere and left hemisphere patients do equally. When there's a manual negator, like in the example I showed you, they actually do equally. That difference there is not significant. But the right hemisphere group are worse than chance. Chance would be 50% correct. They're at about 30% correct when a manual negator is not present. They really seem to be unable to understand negation when there's no manual marker. Does that mean that, and we've seen they don't understand facial expressions, does that mean they can't get any information off of the face? So we did a lip reading task, but this was a very easy lip reading task. So the first task, they just watched the researcher silently say the numbers from 1 to 10 without voice. And then they had to point to the number on a piece of paper. I will show you what that looks like. If you know any English, I think you'll find this trivially easy. Okay, and they don't make any mistakes on that. And they don't even make mistakes on a slightly harder task where they have to watch the researcher say some short proper names in English. Okay, so they can extract linguistic information from the face. So we have to conclude that they can, sign language can withstand impairments arising from right hemisphere damage, but some things don't get processed. And what they seem to have problems with is prosodic information. So negation, where there's no manual marker, is marked entirely through visual prosody. This is what they have problems with, not linguistic information. They have problems with affect, and they have problems with prosody. Okay, so let's now talk about the other study. Okay, and this is a study that was done by Tanya Denmark for her PhD on signers who are on the autistic spectrum. Now, if we look generally, not just the deaf children with ASD, there are three characteristic problems. They have problems both using facial expressions and understanding facial expression. They also show very often limited eye contact. They don't like looking at other people's faces. And they have something called theory of mind impairments. Without going into great detail, what that means is they seem to be sort of unable to recognize what's going on in other people's minds. Okay? So Tanya wanted to look at how such difficulties might affect signers with ASD. And she looked at three things: affective facial expressions, negation, and adverbials. So in her first task, she just got people to look at sentences where there was affect expressed, and they had to identify what the emotion was. And healthy deaf children perform significantly better than deaf children who are on the autistic spectrum. And they have real problems with affect, like a demanding personality or someone who's mischievous. And obviously that, to understand that someone is mischievous is understanding what another person's thoughts are, what they're planning. So this seems to show a theory of mind impairment turning up in sign language. Sorry, all sorts of people are looking for me. I do apologize. Okay, we also looked at negation. This is really the same task that I talked about in relation to stroke patients. And here, there really are no significant differences between children who have ASD and deaf children matched. So they find it harder to process negation on the face, both groups do, but there's no difference between the groups. So notice this is a different kind of finding from what we saw with the right hemisphere stroke group. And looking at adverbials, again, children had to comprehend expressions like to be relaxed or tense, something was large or small, and there were different kinds of stimuli. There was signing, right, where you saw just the face of the signer or you saw the face and hands. There were photographs. You can see there are people who are really working hard at running, and then you see a little ice cream and a great big ice cream. Okay, so that was what the stimuli were like. And here, children who had autism were significantly less accurate than healthy deaf children in both conditions. They had the same problems whether it was on the face or whether it was both on the face and hands. Again, see the difference from what we saw about affect and so on in the right hemisphere stroke patients. So what we conclude when we look at these children with autism, there are significant impairments in comprehension of both manual and non-manual adverbials. So we conclude their problems are nothing to do with face processing, but related to a more general deficit. And the explanation is that to understand and to produce those kinds of facial actions, you need to be able to internalize other people's emotions and mental states. So you have to kind of, when you see somebody who's running and is exhausted, you have to be able to take on that feeling yourself. So we would conclude from that face processing problems are not a central deficit in autistic spectrum disorders. They're an indirect consequence of this theory of mind problem. And so that kind of finding actually reframes our understanding of ASD, not just for deaf children, but for all children with ASD. And so for both the stroke and the ASD research, all these people. Some people are just on the phone all the time. We'll go back. Let me return to where I was. So just looking at these kinds of studies, we have lots of insights both into how sign language works, how grammar, prosody, and affect work in sign language, and also we understand something more about, in this case, stroke and autism generally. But as I said, I want to talk about policy and healthcare delivery, which seems a long way from linguistics, right? The issues I want to talk about are the unmet needs of deaf people who have these impairments. The serious inequalities in deaf people getting access to healthcare, particularly where they have neurologically related impairments, problems with assessing signers, and the sort of really serious lack of service provision. I'm going to be talking about the UK, but I expect many of you will recognize, whatever country you're from, some of these issues. So just talking about Britain, if we estimate there are about 50,000 users of BSL, if deaf people are just about as healthy as hearing people, and actually we know they have poorer health, about 8,000 deaf people are living with some kind of neurological condition. Adults, signers. And these conditions might be, chronic headaches, head injuries, epilepsy, stroke, movement problems, and neurodegenerative diseases. We know from research we've done looking at children that 6% of them who have perfectly normal intelligence and have good exposure to sign language have specific language impairment. And we know that probably between 500 and 700, and in fact people say probably near to 1,000 signers have Alzheimer's disease. We did a study back in 2003 when we were doing our stroke research to find out how many deaf people who'd had strokes had ever been referred for a language assessment following their stroke. So we contacted 264 language therapy services and asked them how many deaf people had been referred to them over 5 years. And the total was 34 services had had referrals out of 264, and a total were of 39 deaf people. And almost all of these had been referred for swallowing problems, not for communication problems. We actually estimate that those figures represent less than 20% of the number of deaf people who have communication problems as a result of stroke. The language therapy, speech-language pathologist teams usually didn't have any staff who could sign, and they often didn't have very good access to interpreters, and certainly not to interpreters who understood about assessing language following stroke. So we can conclude, and I don't think the picture changed much after that, that lots of deaf people have unequal access to language therapy after having a stroke, and that even the people who are referred don't get any therapy. And therefore, the consequences of a stroke are more severe, because we know that therapy is very helpful, especially if you get it soon after a stroke. So, why do we need to do something? Okay, we've got lots of reasons why deaf people need specialist assessments. There are unique cognitive signatures in deaf people, and you need expertise to assess them, and clinicians need to be fluent in BSL. The existing tests that people use, if you're lucky enough to get referred, are not suitable. They're not normed with signers, or they're not validated. They take no account of cultural differences. They don't take account of the poor literacy that many deaf people have. Interpreters are often not very helpful. And most clinicians have never seen healthy deaf people, so they don't know what the problems are. I mean, they've not seen any deaf people. Tests for users of spoken language are just not appropriate. You can't just translate tests. You're not comparing like with like. There's some things that deaf people do better on than hearing people. Unless you look for that, you don't know what's wrong. Having tested 250 elderly signers, I've been told I only have 4 minutes left, so I can't show you any of these things. Okay, actually the distribution of intelligence in the deaf community is not the usual kind of distribution. What we mean is there's a greater prevalence of undiagnosed problems in the deaf community. So it's not even that they're not getting equal access, they have more problems. I have lots of these case studies here, and I don't think I have time to read them, but they basically are patients or family members we've talked to saying how in this case the assessment was wrong and the person was misdiagnosed, and this person saying if she'd been diagnosed earlier we could have had more time with her and really she would have had a better life. The case study here, the person was completely misdiagnosed. The doctors thought that this deaf person was fine, but the family member knew that he had problems. He knew that his father had aphasia, but the doctors never recognized that. They thought he was fine. He also spent months in the hospital because they didn't know what to do with him. So deaf people often get placed in residential care homes where nobody signs, so nobody knows whether they have any cognitive problems or not. If they're diagnosed late, they don't get access to medications that might slow down the progress of the disease. Bad assessment leads to poor access. Families can't sort out care arrangements, and in the end, it costs more to society as well as to the individual and the family. So we developed and normed a cognitive screening test, which can be developed with deaf people and with healthy deaf people so that we can now diagnose cognitive disorders in deaf people accurately. We went on to work with the local neurological hospital, which is a national service, to create, we have a monthly clinic for deaf people in which assessment is in BSL. And actually yesterday, the National Health Service, NHS England, met to decide whether this service should become a national specialist service for deaf people with neurological problems. So you see how you start with a little research and you can end up really impacting positively on people's lives. The case study, the third case study, which we don't have time to look at, is somebody saying how after 20 years his mother finally came to that clinic and got the correct diagnosis. She had been from doctor to doctor and never got a correct diagnosis and had a bad experience. So I'm going to conclude by saying what we need are publicly funded specialist services so that we can provide early diagnosis and intervention. We need appropriate training for interpreters. We need assessments for deaf adults on cognitive and language abilities. We need networks of support groups for deaf people. You know, a hearing person who has dementia can go to a day center and you know, a deaf person can't go there because nobody can communicate with them. There need to be more specialist care homes, residential facilities, independent living facilities for elderly deaf people. And the deaf community itself has really little access to knowledge about any of these problems. So we need to actually work together to improve awareness so that deaf people will come forward, recognize there's a problem. I mean, we've had people we've seen who didn't know they had strokes because they didn't know anything about a stroke. They didn't understand why they couldn't use their arm anymore. I mean, this is wrong for the 21st century. We're just about to put a West European health project together to do something about this internationally at the European level, to set up a healthcare platform, to do more neurolinguistic research, and to create a European training qualification for deaf people and hearing people who want to work in health professions with sign language users. And you know, we need to meet the needs of deaf citizens. We need to ensure full communication. And as I've said, you know, if you don't provide for the sign language community, you are not providing for the community as a whole, and therefore what you do will improve services, not just for signers, but it's also going to improve services for hearing people and for hearing impaired people, those who've got hearing loss in adult life, and so on. I'll stop there.
I'm just going to move this chair unless you want to sit in it.
I can sit in it.
Okay.
But here, take this.
Yes.